And should we sort of go through the general guidelines with hinge joints? Is this the time to do this?
I think so.
All right.
I think so. And perhaps I could just identify some of these, and then you can speak more to exactly what you look for in the clinic. We like to identify, first of all, you need to identify the objective sign. You need to identify the restriction of motion and the measurement thereof, or perhaps the fact that they have pain, and just make a note of that.
Yes.
And then you're going to mobilize now in the direction that turns off the pain.
Yes.
Following that, well, as you mobilize, then there's various different critical aspects of that mobilization, which is the amount of force that you use, the direction of force, and can you speak a little bit to the force necessary and the movement you expect in the finger, for example?
Well, as a manual therapist, you need handling skills. If you want to manipulate a joint, if you haven't got handling skills, you'll never manipulate it. Now just think about the finger. It's a little joint. And to reposition a very painful little finger, you've got to have, one, handling skills. Two, you've got to have should we talk about some of the...
Yes.
Like we put on a board an acronym CROCS. Well, I'll just talk about some of that. You've got a finger. First of all, you've got to have handling skills. In other words, you don't squeeze it. If you've got a swollen joint, the patient will probably kick you. Right. But you must just secure the two parts of the joint. Now, you're going to carry out a translation. In other words, you're going to reposition it, say, medially or laterally, which is the first thing you do with all hinge joints. So you get hold of these structures and you translate them medially and laterally. How much force?
That would be at right angles to
the motion taking
place, the physiologic motion. And also, where would your thumbs be? Would they be close together or far apart?
If this joint is minute, and if your fingers are separated, all you're going to do is start not translating, but just side flexing or side bending the joint, which it would object to.
And so you ultimately call this a hinge joint or a freely mobile joint. And so you would do a medial or lateral glide. Is there anything else that you might do if that was not successful?
If that's not successful, then you would try, with all hinge joints, a rotation. But always, the first thing, you must have knowledge. You must know exactly where the treatment plane is. Now, the treatment plane in a joint is a straight line at right angles to the shaft of the bone across the concave surface. You go straight across. And here, the concave surface, of course, is the base of this phalanx. And you've got to make sure you go and use the treatment plane. Otherwise, it won't work.
Okay. And in your experience with mobilizations with movement, as you initially discovered them and then you found how they worked best, what did you find added to the long-lasting result in there? What did you need to do?
I forgot to tell you, Don's not stupid. Now, you get hold of a finger. It's painful, it's restricted, you reposition the surfaces, and there's no pain. The patient now starts to bend. Now, they can't perhaps go all the way initially because it's been stuck. Another point, of course, is all the way through that motion. If I correct this, it must be sustained all the way through. If you let that pressure off halfway through, it might recoil. And now they're in agony. So you sustain it. And the success of every technique or mobilization with movement technique is dependent on when the patient has gone as far as they can, applying some overpressure, which is a passive movement. In other words, you must go further, because all joints have an increase in motion when you try to move them passively. I go to there, the moment you push that down, it goes further. That's as far as I go. And so to get a lasting success, I found, as a result of experimentation, you reposition the surfaces, you bend the joint, and you give overpressure.
Do you have to do a certain number of them?
Now, in the case of that girl, I probably did it 3 or 4 times, and I was a bit nervous. Oh, I've got a result. Let's not stuff it up. Can I use that sort of word? It's like a chicken. You don't sort of get it wrong. But anyway, I just did so many because we had a result, and when she came in 2 days later, it had
Improved?
Yes, she'd regained full function. And it's revenue reducing, of course. I only saw her twice. Bless her, she opened up a whole new world for me in manual therapy that and I can't believe it had never been done before. If if you had some result from some particular glide after doing it, why didn't we just sustain it and see how we got on? I still can't believe it was never done. And I was just as stupid. I was teaching manual therapy for all these years, and I didn't come up with that idea. It happened by chance.
So talk to me a little bit about what happens if you do the mobilization with movement and the symptoms actually return after you've finished doing your repetitions with overpressure and there's still some symptoms left in there. What might you do? Or is there anything?
Well, you need handling skills. It could be that the main positional fault was a translation medially or laterally. It could be that there may be a little bit of rotation involved, and just by adding the correct translation with a little bit of rotation, you might complete the picture.
Can you do something to sustain that if as you take your hands off, that the patient still has some symptoms?
Well, you can, of course, not necessarily with a finger, but with many joints you can, sustain the correction using tape. Is that the answer you wanted?
Well, actually it is.
Oh, thank goodness. I got it right. All right. It's like being on
and the other thing is that you can also instruct the patient in a home exercise program. And with a joint like this in the finger,
thank you for being here.
Can you teach them to do
Sometimes
that themselves?
you can. Yeah. They can just support one side of the joint and push, translate it themselves, provided they're accurate. Yeah. They'll do it. If it's painful, they're not to persist.
And a number of my patients can't do that. So I just go ahead and put a piece of tape on them, and sometimes that works well
that
for them.
That does work.
Okay.
Yeah, you're right, Donald.
All right, good.
You're right.
Okay, so if you were doing a local mobilizations with movement in the proximal interphalangeal joint of the finger, and you had tried this mobilization combined with motion, and you are not getting the desired result. You are getting a change to the condition, but you're not getting abolishment of the symptoms. You can change the location of your hand, exactly where you're mobilizing the joint. You can change the direction of your force, and may I use your finger?
My permission.
Thank you so much. And as you can change the location, maybe you're just a little bit too far apart, you can move back close to the joint plane. You can glide one direction.
I know the answer you're after. You're looking for subtle changes.
Yes.
If you're getting, all right. If you're getting a result, but it's not complete, you need to make a subtle change. And that raises an issue that I didn't make. Can I have your finger again? You get hold of a joint, you try a medial glide, ouch! You try a lateral glide, they say, oh, it's only a bit sore. It mustn't be sore, and you can tell them about the pill in a minute. And therefore, to make sure it's not sore, you make the minute subtle changes in your direction of force.
In force or direction,
Yep. And suddenly, no pain.
The patient always reports, often in my cases, that, oh, that feels better.
Oh, yes.
And I think, and that's what they're there to do, is to feel better. But they might be 70% better, and they're saying, this is great. But you want to know how much pain. So it's kind of important to communicate with the patient and let them know that you want to know the exact level of pain. Yeah. You're looking for no pain.
Can I just correct you on one thing?
Yes.
Not correct you, that's wrong.
Absolutely.
He used the word better. The patient says that feels better. I expect the patient to say, not better.
No pain.
But no pain. So you better tell them about the pill effect.
Yeah. Okay. So
earn your keep.
Well, pill, this is kind of your word, but this is the pill that you usually give to the patient, right? It's a pain-free technique. It's I for instant change. You don't have to wait. You don't have to prepare them with ultrasonic for 3 weeks like you normally say. Oh, well, that's just to get the revenue up. And then, but you do expect an immediate result if these techniques are indicated. And not only are they pain-free and immediate, in their result, but they are also long-lasting. And I guess the guideline that you would use is the majority of the gain, the objective gain that you achieve within your patient is kept until the next visit.
And something we haven't said is that mobilisations with movement should be applied on every joint that you encounter that has a problem. It could be a sacroiliac joint, a spinal joint, or an elbow, a shoulder. But on every structure, you should apply a mobilisation with movement as part of your routine assessment of all patients. Only by doing this will you know if they're indicated. And when you use them as an assessment and you get a pill response, they now become a treatment. So initially, they're used as part of your assessment. Your clinical reasoning immediately tells you, gosh, it doesn't hurt, it's going to move, I'm going to repeat this procedure, and this patient's going to get better. So I like the term pill. Just one clarification of P for pain.
Yes.
The mobilisation must produce no pain at all, or the repositioning, and neither must the motion or the movement or the function. We also, sometimes instead of a motion of a joint, it may be a muscle contraction. And when you apply a MWM, there is no pain with the gripping. Yeah, or it may be sacroiliac joint, reposition the sacrum, and the function is walking.
Yeah, we'll get into that a little bit later.
All right, I'm sorry.
Yeah, no, that'll be perfect. But the other acronym that you referred to was the acronym CROCS. And CROCS stands for contraindications.
Yep. Good.
Okay, because there's always contraindications to manual therapy. Okay, that we expect that the therapist will be aware of.
Yep.
Secondly, repetitions, performing sufficient repetitions in order to have a long-lasting effect.
Yep.
Overpressure.
Yep. Essential.
Yes.
Yep.
Communication with the patient, because without the communication, you don't know if it's the condition is pain-free.
Yep.
And, of course, application of your knowledge. Can you speak a little bit more to knowledge and also the S of CROCS?
Knowledge. You've got to, first of all, have a pretty good knowledge about all musculoskeletal conditions. If you don't know anything about musculoskeletal conditions, you can't be treating them. You've got to have a knowledge of your anatomy. You've got to have your knowledge of your joint surfaces. You've got to know exactly what's beneath the skin. When I look at an elbow, a wrist, all I see is the radius and ulna, and I know exactly where the joints are. I know exactly where the treatment planes are. Knowledge is absolutely essential. And just a word, you mentioned communications. I would never treat a patient without, before I start, telling them what I'm going to do. And I'm really emphatic about the no pain side of things. And so if they don't understand English, I can't treat them because, and so often with some people you treat them, and after you've treated them, they say that was painful. They must tell you before they go through that experience. Good. So we got to knowledge.
And for the S, it's useful for a number of things. The words that come to mind are sustain and sense and skill and success.
Can I sustain? Can I just say quickly?
Yeah, do it one at a time.
You've got a joint that's extremely painful. You reposition the surfaces without pain. Now you carry out a motion. Now, if halfway through that manoeuvre you want to blow your nose and you take your hand off, that could cause agony. The joint could recoil to where it shouldn't be. So you must sustain your repositioning or your corrective translation all the way through the movement until you return back to the starting position.
How do you do that without restricting the joint motion?
Oh, there's no problem. If I am repositioning the bones of your finger, I must go with the moving joint.
I see.
And they must move slowly. The actual translation, correct translation, is so critical that if you move your finger quickly, I've lost the translation. I must stay with the moving joint. And that's absolutely critical again. Slowly. If you've got an acute joint, do it slowly. Yes,
that's another
S for slow.
Yeah.
You've got it written there. S for sustain. S for common sense if you've got it. S for skill. And if you haven't got handling skills, don't even try these techniques. You've got to have it. And S stands for successful. These techniques are very good when indicated.